Hello, everybody. Thank you for joining us for this talk. And we're going to talk about some common challenging scenarios. We recognise you are still dealing with uncertain and difficult times, and I hope that this presentation will provide some food for thought. So my name's John Dale Skinner. I'm one of the medico-legal advisors here at the MDU. I'm also a practicing GP, and I'm joined today here with Dr. Sarah Jarvis, who is a medico-legal advisor at the MDU, and also Dr. Charlotte Jones, who's a GP partner in Swansea. And Charlotte, would you like to tell us something about your background? I understand that you've got a role in the BMA and the LMC.
Yes, thank you very much for that, John. I'm delighted to join the MDU today. I'm a GP in Swansea. I'm also a GP trainer and GP appraiser, and I work out of hours. But until 2019, I was the chair of the Welsh GPs Committee for 6 years and have been a member of the local medical committee for about 15 years, having recently stood down from those roles. But I have a large and extensive background in medical politics, obviously, which comes with those roles and helps with the subject matter that we're discussing today, as well as my own personal experience being a GP partner for over 20 years.
Thank you, Charlotte. Well, Sarah and I are really pleased you can join us. And so while this presentation provides some general advice, we recognise that dealing with these types of scenarios can be very difficult and stressful. So please remember that we've got our advice line for MDU members, where you can speak to one of the medico-legal advisors regarding individual cases. You can also email advisory@themdu.com if you would like some written advice on any difficult medico-legal scenarios. Okay, well, over to Sarah, I think.
Thank you. To start this session, we'd just like you to take a few moments to think about a challenging patient or encounter that you've had. For example, perhaps you've been called to reception because you could hear some shouting, or perhaps you're feeling that the patient's demands for practice support and contact input have now become unreasonable. And it's helpful to think about how you reacted to that and how the incident made you feel and what you did afterwards. Charlotte, sometimes it can be very helpful for the doctor to consider why the patient has been challenging or difficult. Can you think of anything that you would advise your colleagues to do when they're dealing with situations where a patient is being rude or is being challenging?
Yes, it is a very difficult situation when you recognise this behaviour, and sometimes there is not any explanation. But it's always helpful to try and think and explore whether there are any potential underlying reasons that could be contributing to the patient behaving in this manner. In the first instance, consider whether they are in pain or distressed, as this may influence their behaviour. Of course, they could be frightened, they could be anxious, they may also be very frustrated with the situation, which has influenced how they've behaved today. An example of this could be a 24-hour carer who is feeling frustrated at trying to get through to the surgery and not being able to do so. And they therefore then vent those frustrations within the surgery environment. Other factors that can sometimes influence the presentation could be substance or chemical misuse, or expressing concerns with a lack of understanding of how the system works, and availability of appointments, something which we're dealing with on a daily basis, particularly at the current time. Sometimes they may be feeling guilty. We've all seen that the parents who are presented late with a very sick child, so that guilt may be projected through in behaviour which is perhaps not very helpful to the surgery staff. So we need to keep an open mind as to any potential reasons contributing to the behaviour, but we must always remember that we have a duty to look after ourselves, we have a duty to look after our wider staff, and that such behaviours should not automatically be tolerated. And even if there is an underlying reason for this, then we need to explore that, but also make it clear that the patients should not be behaving in this way and the impact their behaviour has on the staff as well as ourselves.
I think, Charlotte, what you're saying is that we don't feel that sort of difficult or challenging behaviour should always be tolerated. I suppose here at the MDU, it's quite common for us to be asked about a situation where a patient has been very rude and perhaps the practice is considering removing the patient from their list of registration. And I think if we look at the grounds for removal, it can be helpful to bear in mind the threshold for that. Because of course a patient can be removed from the list if there's been violence or aggressive behaviour, if there's been any discriminatory abuse, if the patient has made sexual advances, if they've stolen from the practice or staff or patients within the surgery. Those are all reasons why a patient can be removed from the list. I think sometimes we do get concerned when we hear that a surgery wants to remove a patient from the list because the patient has made a complaint. And in fact, GMC guidance is very clear on that point, that you can't remove a patient from the list simply because they have made a complaint or brought a claim. And I think it's helpful to remember that sometimes the behaviours and a very stressed situation can lead to both a desire from the practice to get the behaviour to change, but also a desire from the patient to make a complaint. And I think a key piece of advice here is to separate processes. So you may need to deal with a complaint separately from consideration as how best to deal with patients' behaviour as well. I think it's important that if there may be some underlying contributory factors to the behaviour, that need to take that into account, and hopefully to get that to be resolved, to try and sort out that underlying issue. Something that we often get asked is whether the family of a patient who is being off-listed should be off-listed as well. And Charlotte, what would be your advice in regards to that?
Well, I think doctors need to be very careful about removing whole families from their list. In general, it is not appropriate to deal with the problems caused by one person on the rest of the household. So therefore, just because one member of the household has behaved in an inappropriate way, that does not mean to say that you should assume that the doctor-patient relationship has broken down with a wider family. I mean, it's quite clear with the BMA and their advice about when you should remove patients immediately from the practice. And we've touched on that with the example you've given, Sarah. Violence or threatening behaviour by the patient implies a total breakdown of the doctor-patient relationship, and also total abrogation by the patient of any responsibility towards the doctor, and will normally result in immediate removal from the list. And of course, we mustn't forget, as well as having a right to protect themselves, GPs have a duty as employers to protect their staff. Now, we will be sending a link to the GMS and PMS regulations regarding removal of patients from a list, but it is absolutely critical that the surgeries and doctors follow the due process, because without following that due process, they could be leaving themselves open to difficulties further down the line. And I also feel the contemporaneous record keeping of all such incidents is vitally helpful, again, when dealing with potential outcomes when we are removing patients from lists and dealing with complaints and all the sequelae that might come with that.
Thank you, Charlotte. And of course, as well as GPs having their contractual obligations, they also have to follow the guidance from their regulator, the GMC. And I know that we're all familiar with good medical practice, but paragraph 62 of that advises, quote, that you should end a professional relationship with a patient only when the breakdown of trust between you and the patient means you cannot provide good clinical care to the patient. So as we've already alluded to, Charlotte, there are processes that can be done, and an expectation that as doctors, GPs have done everything they can to try and get that doctor-patient relationship back on track, because that would be the hope and the aspiration that we can move forward from these circumstances. And generally, the GMC guidance also sets out an expectation that patients should be warned that the relationship is at risk, and to look at what you can do to restore that relationship. And they also suggest that you should discuss the situation with an experienced colleague. And I think that that's something that is so important, that doctors can often feel isolated and very frightened when these situations occur. And often these decisions are actually much better made by a group of doctors, and also sometimes it's important just to be able to discuss things with a sensible colleague. And just to remind you of what we've discussed already, that generally it is not appropriate to remove the family of a patient for one patient's. We've already touched on the fact that separating complaints and other processes from warnings about patients' behaviour is very important. The Ombudsman can be quite quick to investigate cases if the patient believes that they have been unfairly removed from the list. And so I think it's important to make that delineation if you are having to deal with a complaint and with a concern about patients' behaviour, to deal with that as two separate matters, making it very clear, because if you don't do that as you're dealing with the situation, it can be very difficult to unravel. So I think if there's a complaint, you have to deal with that separately and then tackle the behaviour issue. Is there anything else, Charlotte, that you think is important to touch on?
I think really the key here is to have a consistent approach to dealing with the situation. We have many staff in the practices and we do need to have clarity over what each staff member should be doing in these instances, but have a consistent, clear approach. That consistent, clear approach needs to be visible to patients so they understand what the process is. That can be highlighted in patient information leaflets, websites, Facebook sites, or any other way that they communicate with the public. And I think it's important that regular training is done on these on this matter, so that staff are reminded regularly and refreshed in what to do should these instances happen. And also we need to remember that although we need to deal with the incident as it happens, we need to follow all the processes that we've got in place, keep regular training. We mustn't forget that we still have a duty to provide immediately necessary treatment for that patient, even if that patient is behaving in an unacceptable and demanding way.
Thank you. And as a partner in practice, Charlotte, how do you deal practically with these difficult situations?
Well, firstly, I try not to take it personally, and that can be very challenging. I will usually assess and minimise the risks to me and the wider practice team, so to establish what I can do that's safe, that provides the immediately necessary treatment to the patient and deal with that clinical need, but then look into the wider issue of the behaviour. I need to establish what has happened, which may involve taking witness statements from staff, maybe other people in the building. I may have to listen to telephone calls, and then I would discuss the event with staff and with a wise colleague. One, to help the staff debrief, and secondly, with a wise colleague to make sure I'm getting some support to make sure we make the right decisions on this event, and also then to agree a consensus on the actions to take forward and the next steps. It is important because, of course, we do have the option of providing a verbal warning with or without a suggested behavioural contract, or the more formal outcomes. But it is important that we understand what we're going to be doing and do it consistently so that it is fair to everybody. It's only in the more serious circumstances where the police have been called regarding an incident, and in those instances we get a crime number obtained, and then we can immediately remove that patient from the list. I think it's important that we again let patients know of our zero tolerance policy and that we widely publicise that, and also remind our staff that it is not acceptable for them to be verbally or physically abused. It's important, as I've said earlier, that we regularly refresh our training and update our staff on the mechanisms to follow, and make sure that is included in any induction packages for new members of staff. And also make sure that staff are available of the avenues of support open to them, not just within the practice, but perhaps wider, particularly if their mental or emotional health has been affected by these incidents. We need to try and embed debriefing post-incidents into normal practice, and that's something that we do routinely here within the practice, and we find that really helpful. So it helps all staff to know that they're not alone in facing these difficult scenarios, and it enables support to be given to the whole practice team. It also helps remind them that there is a defined process in place for managing these instances, which thankfully are few and far between. I think it's important to try and get any complaints resolved as quickly as possible so that we can get the doctor-patient relationship back on board as quickly as we can, as you've already said, Sarah. And as I've alluded to before, it is vitally important to have contemporaneous notes for such incidents, and using the LMC or the CCG to support the practice where appropriate to do so. And we've certainly used the LMC before for advice in difficult, unusual circumstances. It's important that all practices follow the correct procedures to protect themselves by making sure that they don't breach any contractual requirements, but also to enable you to be able to justify any action taken should the complaint or the concern be escalated, as you mentioned, to the Ombudsman, to the Health Board or CCG, or even up to the GMC. But we mustn't forget that we have to acknowledge how stressful these situations are, and they're stressful for the doctors and the wider staff, and there are some excellent resources out there, and these I understand will be included in the links, but I would not underestimate the support you can get from your defence organisation, from the LMCs in the areas, but also from Health for Health professionals in Wales and their equivalents, and also the wellbeing services that are widely available to all staff, and reminding staff that they are available for them to use.
Thank you, Charlotte and Sarah. That's very helpful. Shall we now move on to case study 1? So this involves patient A, who turns up to the reception of the practice, which is providing services in a COVID secure way. And the patient turns up at the door and the receptionist takes their name and asks them for their details, and explains that they're not allowed to enter the building because the patient is not wearing a mask and they haven't sanitized their hands. And at this point, the receptionist says that in order to enter the building, they must wear a mask and also sanitize their hands. The patient becomes enraged and he says that COVID is a load of nonsense and the receptionist should do her effing job and let him into the building. Clearly, this is an upsetting time for the receptionist, and her colleague comes over to provide assistance. The patient then barges past both of them and turns up at the reception desk and demands a repeat prescription immediately. I think it would be quite useful to think about how you might deal with this in your own practice, and I'm sure some of you will have had similar experiences. But in these circumstances, in this case study, it transpired that the patient was caring for a frail elderly relative who was extremely unwell. And the practice recognised that this was unusual behaviour for this carer, who was normally very respectful towards staff. And it was decided that in these circumstances, the practice manager would pick up the phone and talk to the patient and explain the effect of their behaviour on the staff members concerned, but also signpost the patient to services which are available to carers. So in this case, the practice were able to deal effectively with the situation. The patient apologised for their behaviour, and it seemed like the practice manager had been able to get things back on track, which is the most important thing. And the practice manager was able to arrange to speak to the members of staff who are concerned and make them aware of the apology. They had a bit of a discussion informally over a cup of tea and were able to move on. But there is probably one thing to say with this case study, and that's a concern that members have sometimes of patients recording in the practice. It can be quite easy for somebody to start getting out their phone and trying to video what's going on. And while a patient can record their own consultation, because the data in that consultation belongs to them, it's important to take care if they're trying to record anywhere else in the practice, like a waiting room, which could lead to the breach of confidentiality of other patients. It's helpful, therefore, to have policies in place at your practices about dealing with this, so that everyone knows to follow them, and that the patients can be advised of those policies. Sometimes practices contact us because they are concerned about complaints on social media. And at this point, Charlotte, have you got any tips for dealing with complaints or comments that people have made online or in social media?
This is such a tricky one, isn't it? Because you've got to try not to take it personally, and that's really hard with social media. It's difficult, and all I would reflect is that, you know, patients have always grumbled about doctors, perhaps not their doctor, but sort of wider doctors, and we're experiencing a lot of that with negative media coverage. But with social media now, it is so easy for matters to be shared very quickly, far and wide. However, it is often the case that the messages left on social media are actually saying more about the writer of the post than actually the person or organisation that they are complaining about. So I think it's important we try to remember that. It's always helpful to take these things away from social media, so not to engage in a discussion on social media about this, and to make sure that any responses ideally are made directly to the patient through the normal channels. So you're not ignoring the complaint, you're dealing with it, but in a more appropriate venue away from social media, but recognising that can be a challenge when you read something that feels quite unfair and difficult.
Thank you. And Charlotte, when sometimes patients are dealing unreasonably with staff, for example, by sending multiple emails, by telephoning over and over again, or being very demanding about, I suppose, the resources of time, which is so very precious at the moment. And how do you deal with that?
I think the key here is having a consistent approach. You need to make the patient aware of the impact of their behaviour, whether it's repeated calls to the surgery, whether it's the tone of their conversation or the messaging that they're giving, and they need to be aware of the impact of their behaviour. And that is where, if you know, they don't listen or take that on board, or it's ongoing, or it escalates, then, you know, you do have to think, is this now at the point where you need to use a warning letter or behavioural contracts? And these can be extremely helpful resources to consider using. There is some guidance on the use of both of these tools, and we will include some links to these for practices to consider using. But it is important that when you recognise undesirable behaviour, that you address it as soon as it has occurred. Because let's not forget, as an employer, we have obligations to protect our staff, and of course patients attending the surgery may be vulnerable and or unwell, and it can get very messy if an inconsistent approach is used, or if behaviour goes unchallenged and then escalates, as sometimes practices may want to remove the patient from their list but haven't gone through the necessary steps, and therefore they are leaving themselves vulnerable should they then remove the patient without having followed the due process. So by following policies and issuing warnings and following the due processes, the practice can protect its position if the matter subsequently escalates and they do end up removing the patient from the practice.
Thank you. Any experience of acceptable behaviour agreements in practice, Charlotte? So times when you think that these will be very useful because they are advocated as a way of resetting boundaries and providing a clear framework for the doctor-patient relationship. What types of circumstances do you think that they're useful for?
Well, two circumstances immediately spring to mind. Patients on drugs of addiction or have the potential for addiction, whereby you agree a frequency and a quantity of medication to be prescribed, and you set that out in writing, the patient agrees to it, therefore you are both agreeing to what you're going to provide and how frequently, and there should be no manoeuvre outside of those agreements unless it's clinically indicated to do so, in which case you reset the behavioural contract. The other circumstance I can think of, again particularly pertinent at this time, is where patients are repeatedly contacting you where there's no real clinical need to do so. And I think it's important that we have to make sure that there is no clinical indication for these repeated contacts. But where there's not, I think we have to make it clear the expectations of what we can deliver, and actually when it is appropriate for them to contact the surgery. So if there's a clinical medical need, yes, contact the surgery. But for other problems, that is inappropriate, and that any further examples of that will be dealt using the contractual mechanisms that we have. And again, I stress it's really important you have a consistent approach across the practice to this to avoid any potential difference of approach to the management of the problem, which can then create inconsistency and then cause problems in the future, particularly if things escalate.
Thank you. And I think quite often it can be helpful for letters for acceptable behaviour agreements to go out in the name of the partnership to make it clear to the patient that this has been considered by all of the clinicians involved. And so it's not going to be possible for them to try and go back to someone whose name was not on the letter to obtain, for example, the medication that we've touched on already. So absolutely, that consistency is key here.
An excellent point, Sarah. That's exactly what we do. Send them out in the name of the partnership, not an individual.
Thank you. Perhaps if we turn now to case study 2. So another patient A who's been removed from the lists of their 2 previous practices because of a breakdown in the doctor-patient relationship. He's a frequent attender and can be quite brusque to the receptionists, such that other patients have actually commented on the behaviour that they've witnessed in the waiting room when they go in to see the clinician for their own appointments. He swears at the receptionist because his repeat prescription was not ready when he turned up to collect it. Like most practices, the practice asks for 48 hours to deal with these requests, but is generally much quicker. He ordered the prescription at 10 o'clock this morning and turned up at 5 o'clock the same day. He threatened the receptionist, who explained it was not ready, and said he would jump over the counter and sort her out. He waved his fist at the glass screen and hit the glass screen twice, and told the receptionist that she'd better watch out when she's walking to her car. The receptionist is very distressed. How would you deal with that?
Well, thankfully, such events are rare, but they are very distressing for staff members involved. So whilst generally you would be expected to try and repair the doctor-patient relationship, here there has been clear evidence of violence and aggression. And I think it's completely appropriate in these circumstances to call the police, obtain a crime reference number and seek an immediate removal of the patient from the practice list and refer them to the safe haven or the equivalent scheme wherever one is practicing. GMC guidance recognises violence and aggression as being a reason for the doctor-patient relationship breakdown, and the BMA guidance and contractual guidance is quite clear on this. I would, of course, as another side to managing this problem would be to make sure that the receptionist is okay after such an incident. I would wish to undertake a debrief, make sure that they have time to explore how they're feeling about it, utilise the policies and processes in the practice, and make sure that at the end of the day, she feels safe and we've dealt with the problem.
Thank you. And of course, it might be necessary to provide the police with some demographic information about the patient, their name, their address, etc. But I think it's important to remember that really you shouldn't be providing any clinical information about this scenario there. And I think if there's any query over what you're being asked to provide to the police, the safest advice is to contact your medical defence organisation.
Absolutely, and it might be helpful if we provide some top tips for dealing with these difficult circumstances. The first thing I would advocate is to ensure the practices have policies in place for dealing with unacceptable behaviour and that all staff follow these. And it is important that staff training on de-escalating conflict and dealing with challenging behaviour is up to date, and that the policy relating to unacceptable behaviour is widely available on practice information as well, so that patients cannot claim they are not aware of the policy of the practice.
Thank you. I think we've spoken already about how important it is to deal with this in a timely way, so that if there has been an unacceptable behaviour, that is dealt with in a reasonable timescale, so that there's no delay in dealing with that. Of course, sometimes we need to bear in mind that these situations can impact on the way that we feel about things, and I'm sure you'll be familiar with the concept of HALT, H-A-L-T, that dealing with things when you're hungry, angry, late, or tired is much more difficult. And I would say that sometimes it is important, after you've had a difficult interaction with a patient, to try and take 5 minutes to go and speak with a colleague, get some fresh air, have a cup of tea, so that you can deal with that, but to make sure that the partnership deals with it in a timely way. And as we've already alluded to, sometimes we get files where there's been previously unacceptable behaviour, but it hasn't been challenged by the practice. The practice then gets a complaint in from the patient where there's been a particularly difficult interaction, and the practice then want to include a warning as part of the complaint response. So I think another important take-home point is to keep the processes separate to minimise the potential for criticism, and making sure that you follow your policies, your contractual obligations and the GMC guidance, will hopefully provide a framework to help to deal with these scenarios, but also to minimise the risk of criticism in the future.
I completely agree. I love the halt analogy, but I think it's important that practices have considered the circumstances of each case and feel able to justify the action that they have taken in case the patient escalates matters, and keeping contemporaneous, clear records done in a timely fashion quickly after the incident is enormously helpful should the situation escalate.
Absolutely, and I think a really important point to stress is that you don't have to deal with these matters alone. They can be really stressful, especially at a time when general practice is under such enormous pressure. We really recognise that here at the MDU, and please remember that we are here, your LMC is there, and also colleagues who'd want to support you and to offer wise counsel as well.
Yes, and of course, don't forget your own well-being. I know that the MDU website has a section on support, which is helpful, and always check in with your practice regarding local resources that can be helpful to you, and those which are wider available for NHS staff. As I've mentioned, Health for Health Professional in Wales, and the BMA Wellbeing Support has an extensive range of services available too.
Thank you so much, Charlotte, for sharing your experiences as a GP on the ground who has dealt with these situations as well. I'll hand back now to John just to summarise for us. Thank you.
Yes, well, yeah, thank you very much, Charlotte and Sarah. That's been incredibly helpful. And well, if you have a question listening that you think would be a good topic for us to deal with in the future, then please email us. We've got an email address which is feedback@themdu.com, and please mark your email with video question. And remember, if you do wish to have a personal response regarding a particular medico-legal situation you're facing, then you can always write into us the usual way at advisory@themdu.com, or you can phone the MDU advice line. So I think that's all it, and thank you very much, both of you. And it just leaves me to thank you for joining us, and wish you all well.
Thank you.
Thank you.